Want to welcome everybody to the last CSRO Business of Rheumatology uh, webinar. This has been part of a new series that CSRO has been putting on over the last year, sponsored by Johnson and Johnson, and just trying to get down to some of the things that can help us to continue to survive in practice, get more business oriented. We've had several different ones this year. This one's going to be looking at Medicare drug cost over the year. We know that the Inflation Reduction Act has changed a lot of things, and kind of looking at this $2,000 cap and how it's actually shaping out in practice. For those of you who aren't as familiar with it, we will have some background info that we'll send out with the recap. But this has been something that seemed to be very important, and I think is changing the dynamics of rheumatology clinics, as you'll find out. Next slide. Upcoming for CSRO, we have the CSRO state legislative forecast coming up in February. For those of you who this may be applicable to, we have the Fellows Conference in New Orleans at the Royal Sonesta, March 6th and 7th. And then we have scheduled out all our advocacy conferences from 26 to 28. You can see the dates. We'll be in Washington, D.C. from here on out, and we will be planning a Hill Day along with that. So be kind of tuned to the dates and travel and everything else. So we're going to get kind of two things accomplished there. So without further ado, I'm going to go ahead and hand it over to Jessica, who's going to be moderating tonight, and I'll have the speakers intro themselves. Again, thank you so much for joining.
Thanks so much, Dr. Broadwell. So on behalf of CSRO, I just would also like to welcome you all to the Business of Rheumatology series. And this series was really designed to help support you all in your practices in building and strengthening your businesses. And I'm Jessica Frasco. I'm the Government Affairs Consultant for CSRO. And during tonight's webinar, we're going to explore the new Medicare Part D drug policies that have been implemented in 2025 to really help curb out-of-pocket costs for patients. We're going to discuss the implications of these policies for patient affordability and access to specialty medications, as well as strategies that your practice can use to really adopt and navigate the evolving payment landscape effectively. In 2026, patients have the option to pay no more than $2,100 for all brand name and generic prescriptions for the entire calendar year. And this option has been made available through the Medicare Prescription Payment Plan, or the MP3. Through this program, all Medicare plans will offer a monthly payment plan that spreads out the patient's costs over the entire calendar year, with no interest and no additional fees. This program is particularly beneficial for patients who have high prescription costs early in the year, or those who have difficulty paying for medication costs all at once, or for those patients who are taking multiple expensive medications. The Medicare Prescription Payment Plan is an opt-in plan, so patients can enroll at any time during the calendar year. And once they're enrolled, they'll be automatically re-enrolled each year unless they opt out at any time. So if your patient was enrolled in 2025, they are all set for next year. If they're interested in enrolling for 2026, they have the option to do that at any point during the calendar year. Once enrolled in the program, patients will pay $0 at the pharmacy counter. So no more copays, no more coinsurance. Instead, they'll receive a monthly bill from their health plan after their prescription is filled. And this monthly bill will spread the patient's Part D prescription costs across the entire calendar year. I do want to disclose that patients who have lower cost monthly medications may not actually benefit from this program and could actually end up paying more if they enroll in this program compared to when they use their copay and their coinsurance. So it's really important that patients understand the program and their typical prescription costs before they enroll. And as a reminder, this program is exclusive to Medicare Part D prescriptions and does not include physician-administered drugs under Part B. Tonight, we're going to talk with both a rheumatologist in the dispensing practice, as well as an industry partner from J&J. And at the end of the discussion, we'll leave time for Q&A. So please enter your questions in the Q&A function, and we'll try to get as many questions as possible. Tonight's event will also be recorded and available on the CSRO website for future viewing. So with that, I'm going to pass it over to our panelists for just a quick introduction with your background and a little information. Dr. Solomon, would you like to kick us off? Dr. Solomon?
Yes, sorry, the connection was a bit unstable. Thank you, everyone. My name is Nihat Solomon, a rheumatologist from Arizona Arthritis Rheumatology Associates. I'm the CMO, and we've been doing MID now for nearly 2 years. Slow start up front, and then in 2025, really with the IRA or Inflation Reduction Act a dramatic change was seen. And we'll get into that in just a bit. But thanks for having me and excited to share our experience.
Awesome. Thank you so much. And Kelly?
Hi, good afternoon or good evening to those of you in different parts of the U.S. I'm Kelly Davies. I've been with J&J for 27 years, more than half of that in working in policy and advocacy. Very excited to be here today to talk about this topic. I lead a policy and strategy team for J&J, and we work on federal, state, and regulatory policy, and really looking forward to the discussion. Thanks, Jessica.
Awesome. Thanks so much to both of you. So, Dr. Solomon, I'm going to kick things off with you. And thank you so much for joining us. I think your perspective is incredibly valuable, particularly since you run a dispensing practice. And I think the way we'd love to start tonight's conversation is just to talk a little bit about, since the Part D cap began, what are the differences that you are seeing in patient affordability and adherence?
Yeah, so if you all recall several years back when we treat our Medicare Advantage patients, we typically are stuck or were stuck using either samples, free drug, or look for other means therapies such as research, for example. And typically, when we think about our Medicare patients, traditionally, we think infusions because of the cost dynamics and the proverbial donut hole that had existed with the rather large amount of out of pocket. So, what we've seen since the advent of the IRA and a reduction in the out of pocket cost is better access for our patients with Medicare and Medicare Advantage for folks that require self-administered medications. But not only that, even the ability to run these the infusable medications through the pharmacy benefits in appropriate patients to allow for a cost saving. So ultimately, increased access is what we've identified, and really an ease by which to do so.
That's really fantastic. And Kelly, I think, patient adherence is really such an important aspect for all of us, whether you are a provider or whether you are somebody coming from industry. We want to make sure that our patients can get access to the drugs that they need and that they continue to take those medications. How do you think this program is impacting patient adherence?
Yeah, I do think that, with the new Part D redesign, it's an opportunity for those individuals where, your provider like yourselves and the patient decide on a newer medication, a higher cost medication. And, prior to this reform being in place last year, and now, the benefit design changing for Part D, patients were paying that 5% in that catastrophic. And so some of the newer medications were out of reach for individuals and not affordable. So I think that although affordability is an individual situation and sometimes that $2,100 may still be out of reach for some, I think that there are more opportunities and treatment choices that the provider and the patients can think about that are perhaps new therapies that this gives an opportunity for patients to access, to your point.
Thank you for that. Dr. Solomon, I think you kind of started to talk about a little bit before about how, we think of this program as primarily helping Part D, but there's also this like really fantastic impact on infusible drugs. And just hoping you could dive into that a little bit more, especially for our other rheumatology practices who may be interested in that.
Yeah, so for years we've contended with the concept of white bagging. For those of you who have infusion suites, some of the insurance companies had asked that we obtain infusible drugs through this process called white bagging, which means it runs through a specialty pharmacy outside of your practice. And then there's a little bit of a loss of cold chain command and ultimately lots of risk, especially in a place like Arizona where there's unfavorable weather in the summer, and there could be denaturing of the product, et cetera. And so we weren't excited about the concept of white bagging, but when the concept of MID or medically integrated dispensing started to emerge, and the ability for us to have control and cold chain custody, we would effectively clear bag, which is like white bagging in your own pharmacy or dispensary, if you will. And that allowed for the ability to run an infusible product through the pharmacy when applicable. And so the same benefit of pharmacy of the maximum $2,000 out of pocket would hold true even with an infusible. And as we all know, not every self-administered medication is right for our patients. Sometimes there are no options. For example, if you're looking at a rituximab, there is no self-administered option for that type of medication, and you really need to use an infusible. And so this allows now for access to infusible drugs with our Medicare Advantage patients who otherwise would have to pay 20% out of pocket. And so it really is a remarkable advance and savings, if you will. And I know Kelly mentioned that even the reduced cost may still be out of reach for many. But for those who I believe reach a certain threshold below a certain amount of income, there are various charitable funds out there that could be accessed to help mitigate that. And unfortunately, the days of old with the free drug programs are starting to disappear. And with the advent of biosimilars, some of the originator molecule companies are not supporting those programs anymore. There's still some that exist, and that's wonderful, and we're very thankful for that. But in those cases, it's helpful to have the option to clear bag and get those infusible drugs for the patients who need it.
That's great. I want to kind of pick up on a little bit of something that you said, which was really kind of mentioning those patient affordability programs and those patient assistance programs that are offered by industry. Kelly, can you tell us how is this program intersecting kind of with the existence of those programs? How are those kind of acting kind of in tandem?
Yeah, it's a great question. And first, J&J has, its own programs and a suite of programs. And as the Part D redesign was coming into play and being implemented, we had to do a lot of internal training to make sure that our patient access services team were knowledgeable of the program, and especially the Medicare prescription plan that you mentioned, M3P, which allows that $2,100 to be spread across an annual basis. We wanted to make sure that those individuals who, receive a call from you at an office or a patient or someone in the office, that they were knowledgeable of these changes. I think first is that each manufacturer has their own unique approach. To Dr. Solomon's point, each manufacturer is going to look at their portfolio, look at how they want to administer these programs. I will say we do look at we have a transparency report each year. And for 2024, we had $4.5 billion in patient assistance. Now, that's beyond just the immunology brands that we have and treatments. We have other parts of our business, of course, but we really do an annual assessment assessment each year as to how can we ensure that not only is there access for patients, but there is these support programs. And we still do have free goods programs. But again, I just reinforce that each manufacturer has a different approach. And we have seen some changes within the programs. And so it is an option, to Dr. Solomon's point, that there are not only foundations, but even the Medicare low income subsidy program is really underutilized. I think the last statistic I saw was 27% to 30% of Medicare Part D enrollees are actually enrolled in that benefit. And that brings the cost substantially down. So, in addition to manufacturer programs, it's really important to make sure that, there are other programs out there that are available to Medicare patients. And we try to ensure that our, our patient services teams have the full range of those available for patients and providers when they call in.
That's really fantastic, Kelly. I think, a lot of our patients, especially given the cost of the drugs that are in our space for rheumatology, they really appreciate the existence of those programs. And I think the viability of those programs is really important for us to be able to continue with that patient adherence and medication adherence. So we appreciate J&J's persistence on that, and kind of the collaboration that happens with patients, industry, providers, as we all work to make sure that our patients can get those medications. I'm going to switch gears just slightly a little bit, because there's kind of a component here that, or a player in the system that we haven't necessarily really touched on yet, and that has to do with plans, right? And the plans are a big part of all patient access and patient affordability. And unfortunately, what we've really been seeing is just that these formularies for these plans are just getting skinnier and skinnier. And there are definitely unintended risks and consequences for these thinner formularies, and especially in the Part D space. And so I'd love to hear, Kelly and Dr. Solomon, just any thoughts that you all have on kind of how that is impacting patient access and how that's kind of intersecting here with this program.
Yeah, Jessica, we have seen quite a bit of change from 24 to 25 and even to 26, as we're starting to get a sense of open enrollment and what that may look like, especially in terms of formularies. So a couple kind of macro themes. We're seeing a lot more cost sharing at a higher price point. So again, even though we have today and tonight talking about this cap, which is really important for affordability in the Part D program, we do see that plans have moved away from co-pays and really are doing additional cost sharing. Also, we're seeing less plans available, especially in certain states. So it's important to kind of know what the options are. And although most beneficiaries kind of roll in to the same plan year over year, it's important for them to really take a look to ensure that not only are there providers in network, but their cost sharing and their access to their particular medicines they're taking today actually are on formulary. To your point, we are seeing a lot skinnier formularies and higher cost share. And also a departure somewhat from the standalone PDP program, the individual plan that rides along with traditional fee-for-service Medicare. We're seeing a little bit of a departure and a limited volume of those in certain states and counties.
Yeah, I agree. What we've seen, first of all, there are 10,000 new Medicare eligible patients coming due every day, which is rather sizable. And with that, as Kelly mentioned, there are into Medicare Advantage plans. And as Kelly mentioned, those Advantage plans seem to be shrinking year over year, and there seems to be some consolidation in the market. And so ultimately, what we've seen already is limited formulary dictation of using XYZ drugs as we normally would expect. But now the offerings are even more limited, where we don't have the selection across different MOAs, or we have multiple of the same mechanisms available to us, and that's it, which is problematic in and of itself, asking us to switch from one within the same class of drug three different times before getting them to where we need to get them when appropriate for the patient. So, with the shrinkage of the number of available carriers, there is a concern, at least in my mind, that again, we're going to be told what to do as opposed to practicing medicine the way we were taught, and what's potentially more appropriate for the patient, where you're putting the savings and cost in front of what's right clinically for the patient. So we've got to sort of navigate these murky waters. And as much as we love the traditional Medicare with a secondary, those plans seem to be shrinking in and of themselves. But the market dynamics have also shifted, where with the advent of biosimilars and chasing ASP down, there's a race to the bottom, and many practices have found themselves underwater when being told to use this specific medication, and it's not a sustainable practice for rheumatology. And so I think one of the reasons this is a bit of a hot topic, in addition to access for patient savings as well, and the way the market is shifting, the MID program allows for independent rheumatologists to stay viable. It helps with cash flow in some respects. The dynamics of getting the access to the medication and payment ahead of time saves a lot of practices from going underwater and potentially closing their doors.
That's really helpful. Um, I think one of the other kind of areas that Dr. Solomon, I think, would be really helpful for others to hear is just your experience in the space, having worked in the space and I think pretty successfully integrated MP3 into your practice. Are there specific, billing and operational hurdles that you face with these claims, and how have you kind of navigated that with your team and in order to really make this successful?
Yeah, it was definitely a learning curve, and you need a very solid partner who understands the business of pharmacy. We're rheumatologists, we're not specialty pharmacies, and so I would advocate that if you're entertaining the concept of MID, to do your homework, find the right partner who's going to help you navigate exactly what you just said, Jessica, the ins and outs, the workflows, which plans will let you fill. Some states will allow you any willing provider for commercial plans. Others will limit it just to the Medicare populace. So all of that will have a dynamic shift on your ability to fill scripts. If you are going to entertain running the Clear Bag program in your MID, again, workflow changes have to happen. We have to make sure that the drugs acquired through the pharmacy don't mingle with the drugs acquired through the traditional buy bill model, that they're separate spaces, that this is treated very differently. Accounting processes need to be followed stringently. There's a whole host of compliance regulations that need to be followed as well. And so we've worked with our partner. We've also had to hire some internal folks that strictly do the MID program to make sure that everything is working soundly. And it was a process that took us about 6 to 8 months to really perfect. And I think part of it was luck and part of it was timing, with the advent of the IRA program coming in 25 and us sort of getting started at the end of 23, and sort of navigating our way through the murky waters of 2024, but also recognizing that there's opportunity when folks are on multiple high dollar drugs from other disciplines, and being able to identify those folks where you could piggyback, if you will, and save them a couple of bucks through the Clear Bag program. It's a win-win for the patient all around. But as many of our patients have opted to switch from traditional Medicare to Medicare Advantage plans, again, we had to stay on top of that, make sure that we enroll them in the Smooth program or MP3 program, and make sure that they understand that they have to make the call or they have to get online to enroll. And that way, the other piece is we're not picking up copays. The amount of out of pocket or deductible that they have to pay is billed through, once they're enrolled, is billed through their plan, not at the level of the pharmacy. And so all of these things needed to be discussed with the patient. We had to have a script. We had to make sure that um, patients understood the rollout. And of course, the beginning of 25 was a little nutty. I think we've now finally got it down to a science. We're ready for 2026. And again, I think having a solid partner to help you navigate this would do you very well.
That's fantastic. So I think we're looking into 2026. We're looking at opportunities to start, hopefully, folks on the call are interested in starting to use this benefit, starting to integrate it into their practice. Dr. Solomon, where do you see kind of opportunities or where do you see potential hurdles as you are preparing for 2026 as a dispensing clinic?
Yeah, so just like we call in the infusion world, the blizzard, there's a blizzard on the pharmacy side as well. And that's where you have to authorize everybody ahead of time. And you've got to start at least 6 weeks in advance. So we've been already starting right after Thanksgiving, probably right before Thanksgiving, making sure we have lists. We know who's doing what patients are coming due, and getting ahead of that so that come, January 2, we hit the ground running. And so there's a lot of prep time for that. Foundation money, as you all know, can run out fairly quickly. So you have to identify that. You have to apply for them for those who are appropriate, making sure that nobody gets left behind. So there's lots of planning. But one of the other things to navigate is, as you all know, that, formularies change on the MID side. Thankfully, unlike the infusion side, where you're constantly chasing changes in reimbursement on a quarterly basis, the pharmacy tends to be a bit more stable. It's more either semi-annually or annually, and so you don't see as much of the market shift. And so you could plan ahead and ensure adherence and compliance of the patient. You're not having to rotate through medications rapidly just because the mandate is from one insurance company to another, one quarter to the next. And so my hope is that we continue to have that level of stability. And although the market offerings of different plans are shrinking, that they don't pull any fast ones on us.
Yeah, fingers crossed on all of that. Kelly, for you, kind of as an industry partner, where are you all seeing the opportunities and kind of some of the potential hurdles for 2026 in light of this new program?
Yeah, what we saw in the middle of 25 is we did see a little bit more persistency in terms of medication adherence and fulfillment of medications because of the changes in Part D. It's really early to tell, if that will be a trend, but we're hopeful that it will be. We're very supportive of this Part D redesign and the cap for patients to help with affordability. So I think that, again, we're hoping that the data from the full year of 25 and early 26 really shows more patients stay on their medicines for a longer duration. And then also in terms of just those, other choices like the prescription payment plan through Medicare now. It was underutilized to the tune of the last stat I saw was less than 1%. So I love the fact that Dr. Solomon, you're, putting resources in the hands of your practice so that as patients are coming in early in 2026, they can understand when it might be a plan for them and talk to their health plan about enrollment and maybe look at their financials so that they spread that cost over time and it's more predictable for them so that they can stay on their medicines longer. So I think we're hopeful that it's going to be better for patients, better, especially for chronic care patients that you're treating when they have so much that they have to think about. And this may be something that can be helpful for them and again, predictable from a financial standpoint.
Yeah, I think that predictability for patients is really one of the most appealing aspects of this, right? We see patients so regularly hit with expenses and costs that then kind of disturb the rest of their patient care for the rest of the year simply because of the cost of medications. And we know a lot of these drugs are specialty drugs, and so that becomes really challenging for rheumatology patients specifically. Thank you so much to both of you. I think that is kind of wrapping up the end of our kind of formal questions. I'd love to switch over into questions from the audience. So if you are listening and you have any questions for our speakers, something you'd like them to repeat, something that you'd like clarification on, please send those through the Q&A function. So not necessarily the chat, but you'll see the button on the bottom that says Q&A. Please send those through now, and we'll be sure to ask those to our panelists. I have two questions that have been sent through, and so we'll start with the first one. Dr. Solomon, what are the ways that you are working with your patients to understand this new program? How are you helping them to understand the MP3? How are you getting them to the point in which they will consider enrolling? Are there questions that y'all are feeling like you have to navigate as they kind of consider this program? What are things that practices should be aware of before they or as they start to integrate this into their practice?
So the main thing is to recognize if they're not enrolled in the program, then what will happen is the out-of-pocket is collected at the level of the pharmacy. So you want them to be enrolled. That's number one. Number two, you want them to be enrolled so that, and as early as possible in the year, so that once they hit that threshold, the 2100 for the year 2026 will be divided over 12 months so that it's no more than $170, if I'm doing the math right, per month. Uh, Recognizing also this, that when you identify a patient, let's say mid-year, the 2100 is still there, but it's only divided over 6 months. And so again, there's some math there. And so that 175 is now doubled. However, if they've already been on high dollar cost drugs from other disciplines, it's really important to run that report and take a look at that. So this is some of the things that we've been navigating last year, this year, and last year, and trying to understand. In the pharmacy world, there's access to all of this. It's really cool because, within 5 minutes, you could see what they're on from other disciplines as well, what their out of pocket is, how much have they met, how much have they done. One of the other things that unfortunately, in the beginning of last year, we weren't clear on is when patients are on some of these other drugs from other disciplines and are getting them filled, let's say, from a specialty pharmacy, outside specialty pharmacy, those specialty pharmacies weren't even telling their patients about the MP3 program and collecting the $2,000 right up front. And when I found out about this, it made me livid because I'm talking to my patients, telling them we have a pharmacy. So I wish we knew that. Well, we don't really have that medication to fill. We're only dealing with our own specialty. But when I realized this very quickly, we realized we needed to start a campaign aggressively to help educate our patients so that they know that this program is aware, they're aware of this program, whether they're on high dollar cost drugs from within our specialty or outside, just so that they understand the program exists, that they should enroll in it. It'll be a more stable cost savings to them over time, as opposed to having to pay this exorbitant fee up front. So having a team of folks to reach out to patients is critical. And again, that's where if you have the right partner working with you, they may have that team already in place, having the right script. In this day and age, patients calling patients and telling them you're so and so from such and such place. There's always this high anxiety dynamic. Is this a scam? And so also warning patients when you're having these discussions with them that somebody from our pharmacy will be reaching out to you, and if they're applying for grant assistance or helping you apply through grant assistance, they may ask you for financial documents, etc. This isn't a scam. And so that's another thing, especially in our Medicare age patients, they've been programmed now to, be suspicious of anything and everyone. And so just be mindful of that too. It's better to give them a pamphlet in the office to help them understand the MP3 program, help them understand that they have to make the point of contact to enroll, whether by telephone, by internet, or some other means, but it has to be their initiation to enroll. And I believe, and
That's
correct me if
great.
I'm wrong, Kelly, I believe if they've been enrolled in 25, they'll automatically stay enrolled.
Yeah.
For six is a really nice thing because we don't have to do that all over again. And hopefully they continue that throughout the upcoming years. And so you could focus on the new ones. But for those of you who haven't, and for the patients who haven't enrolled, those of you who haven't started MIDs, make sure that they're enrolled as early as possible. There's no fee to enroll. And if they fall behind on their payments, there are some protections there as well. So it's critical that they get enrolled.
That's
Yeah.
really helpful. And sorry, Kelly, were you going to say something?
I was just going to add that at the pharmacy counter, if they do go and they're not enrolled and the medicine is over $600, that pharmacist is supposed to be giving them a most likely to benefit and a brochure or something to take with them so that they can contact their health plan around this prescription payment plan.
That's really fantastic. And I know J&J has also shared with us some kind of postcards that you can include if you're interested in sharing this information with your patient. As Dr. Solomon mentioned, which was one of the follow-up questions we got, is your office enrolling patients? No, the patient has to enroll themselves, but J&J has given us some really good resources, which we'll share with attendees from tonight and include on the CSRO website as a follow-up to this session that you can utilize in your office, and that patients can get more information on how to enroll in the program if they're interested, in addition to the postcard or information that Kelly mentioned that they should be receiving at the pharmacy counter when they have higher cost drugs. One of the questions here, which is kind of tangentially related and definitely something we talked about tonight, Dr. Solomon, one of our attendees was just wondering, are you helping your patients apply for the patient assistance programs, or is that something that they're doing on their own without your office support?
So, the ins and outs, we have a team that helps us with this. The ins and outs and the specifics, I couldn't tell you. But I do know that, like anything else, whether it's through foundations or whether it's through third parties like manufacturers, any program that exists out there, or any foundation that exists out there, we're giving them the information, we're giving them if there are pamphlets, if there are applications and we have access to them, we're offering that to them, and then they help. They fill it out, and then we help them get over the line, if you will. Looks like something came through the chat about low income patients. You guys see that?
Yeah, I think the question was like, so low income subsidies where people can not have to deal with the $2,100, $2,000, et cetera. That's that kind of narrow group of people that are above Medicaid but have a low enough income. Do y'all help them with that? Or I think you probably look to your partners. I know manufacturers are pretty good at that when you sign up for their hub services. Oftentimes they help that quite a bit because it's in their vested interest to see if they can get the patient on medication. I doubt y'all are super active in getting people on LIS,
Uh,
Nihan.
Us personally, no. Ultimately, like I said, there are various analytics you could run. You can see where they are, how much they've got, a certain income. They could be eligible for various subsidies. We help point them in the right direction. Our partner may help further define where they can get help, but that's pretty much where it stops.
Yeah, Dr. Broadwell, to your point, from a J&J perspective, we do look at the suite of offerings as I mentioned earlier, and low income subsidy is a substantial savings. I think the highest cost sharing is $12.50 for a branded medication. So if somebody is eligible at 150% federal poverty limit, and I know that's a small amount of annual income, but if they are eligible, boy, they can benefit greatly from that program. And as I said, it is very underutilized. About 27 to 30% of enrollees are participating in LIS, so low income subsidy, extra help. And there are other programs as well. And one of the things that we have on the brochures that Jessica mentioned is there's a SHIP program, and they're called different things at the state level. But what's nice about that is they're not brokers. They're actually individuals that are employed at the county level to help Medicare beneficiaries navigate their choices for Medicare at annual enrollment and other, times throughout the year. But they also can help them with looking at other options from an affordability perspective. So it's really good to use those SHIP programs. I think the number is on the brochures. And again, it's just a way to have the beneficiary feel like they are in control and they are knowledgeable about their choices and what additional assistance is out there for them, because it's pretty widespread. And there are state programs as well that help with prescription assistance. About half of the states have those programs. So it's not everywhere, but it's certainly in those states, like a Pennsylvania, where I am. I know they have a prescription assistance program at the state level.
So, Kelly, we have another question that is a little nuanced and a little in the weeds. And so I'm wondering if you would be able to assist us with this one. The question is, if the therapy is not listed on the Part D formulary, but a claim is approved through medical exception, does the copay and coinsurance still count towards the cap?
Yes, so if it's a Part D benefit, yes, any amount that the patient is paying will be, towards that $2,100 for that annual year. So it's important that that individual knows that whatever they're paying, with the exception of their premium, their monthly premium is not part of that $2,100. Their deductible, whatever that cost share is, will be, put forward as a subtraction to that $2,100 over time through the annual benefit.
That's great. And then, Dr. Solomon, we have a question here about how does this program work if my office buys and bills?
So the MP3 program is specifically on the pharmacy benefit. It has nothing to do with buying and billing. If you have an infusion suite set up and you are in a state that allows for a pharmacy or a medically integrated dispensary, and you decide to get into the pharmacy business, as I mentioned before, you could do what we call clear bagging. And in the appropriate patients who need an infusible drug, you can acquire that drug through the pharmacy, not through your buy and billing, and then administer it to the patient. So hopefully that's clarified that, but this is not a program for your traditional buy bill folks. Traditional Medicare patients may have their pharmacy benefit as well through a Part D plan. And again, if you're asking, how do I get a patient from the medical benefits to the pharmacy benefits? Well, number one, you have to have an MID or a pharmacy set up. Number two, the dynamics and the cost to patients is going to shift. It may actually be better for the patient to stay on the buy bill side for traditional Medicare. But if they're on multiple high dollar drugs from various different disciplines, and you can identify that, you may be able to save them that deductible and shift them to the from the medical side to the pharmacy side. But I think that's a very nuanced and small portion of the population that we're talking about.
It's really great. So with that, I think that is the end of our Q&A, or at least the questions that have been submitted. Thank you, Dr. Solomon and Kelly, for the opportunity to just chat with you tonight about this program. Any closing remarks before we hand it back to Dr. Broadwell?
Yeah, I just want to say that this IRA and the MP3 program has really been a benefit to many patients.
Uh-oh, we may have lost him for a second. All right, Kelly, we're going to hand it to you if you have any comments before we hand it over to Dr. Broadwell, and we'll see if we get Dr. Solomon back on some good, strong
Yes,
Wi-Fi.
we didn't have this in the past.
We lost you, Nihat, for basically the entirety of what you said. If you wouldn't mind going through it again.
Oh my. Shot. All right. I said, well, I would have to say that since the advent of the IRA program, the MP3 program, the access to patients has been rather dramatic. It's more manageable, even for those who don't qualify for.
Oh,
There's benefit. Sorry, I not sure what's
Great.
happening here.
you're okay.
That's okay. And then
Kelly?
Kelly?
Yeah, I would just agree that I think it's again a great new benefit design for Part D and pharmacy benefit Medicare patients, and I think you can play a great role as a provider and with the financial conversations that you all have in the office with patients to help them understand this new benefit and the value of the prescription payment plan. If for some will be really, again, back to what we talked about, predictable for those patients and really help them stay on treatment when it's appropriate for them. And thank you for having me today. I think it's a great topic, and happy that you're investing in your practices in this way.
Yeah, I mean, I spend a lot of time with patients just going through, hey, how are we going to make sure and access your medications? I grew up in a rheumatology clinic. That's not the tough part. It's the looking back at the EMR, seeing what kind of game you're playing with insurance, and it's made it easier. I mean, those Med Advantage folks that Dr. Solomon brings up, I mean, we were just struggling constantly getting their income information off to free drug programs. And at the end of the day, when they're on, an anticoagulant or an expensive diabetes drug, at the end of the day, they don't pay anything else for their biologic. And then if we can get them signed up for that smoothing portion of everything, it really kind of gets it good. And especially when you're dispensing, because you don't want to deal with the cash exchange. It's great to just say, all right, here you go. And so that's really revolutionized things. Add in the clear bagging part that Dr. Solomon brought up, and that's a whole nother just incredible opportunity to be able to get, these mandated patients on biosimilars on to medication. It's changed a lot. We're going to have some resources. If you're still not super familiar with the program, or if you want some handouts, that'll come with the email later. But I think we're really kind of turning a corner here where I feel like, especially as we had more and more Med Advantage folks, et cetera, we were seeing the pinch, and now we're finally starting to see a little bit of light. Granted, there's still some folks who can't do all that, but I think that's helping move everything in the right direction. That's what CSRO has been about, just providing good access to quality treatment and medications for patients with rheumatic diseases. So hopefully this was helpful for folks, and feel free and shoot us an email, info@csro.info, if you have any follow-up questions more specific. And thank both of y'all for your time. This was great, and it's been a great business of rheumatology. Thank you, J&J, and all our sponsors for really, really keeping us going at CSRO, and everybody have a wonderful holiday season.